Hello, welcome back. Okay. In this lecture, we're going to go over the basics of the EKG rhythm. We're going to go over what the waves mean and what they correspond to in the heart electrically as well as physically, or you might hear me say mechanically. Okay. And we're going to talk about how to calculate rate because that's very important. So we'll talk about looking at the EKG, looking at something that's called the R to R interval, and we will calculate the heart rate with various methods based on the R to R interval on the EKG. Okay, so that's something that we'll get into. In addition to that, we'll talk about some of the intervals and some of the waves and how some of that stuff can affect us clinically a little bit. All right. And we'll go through the PowerPoint and we'll just kind of make sure that we kind of hit on all the topics between this lecture and the previous, just to make sure that you guys are up to speed. Okay, so once again, I know there's always difficulties associated with learning like this. If there was in a live class, of course, I would always encourage you to ask questions. But what we'll do is if you have questions, just reach out via email. And we'll be sure to get back to you, right? So if you have questions, though, make sure that you get them answered, whether through self-study, self-directed learning, or reach out to us, or it doesn't matter how. The most important thing is the learning, okay? That you are able to take what we're covering and then keep it and retain it and then build on it, because every single thing in EKG builds on the thing before it. So if you have any questions, let's make sure we get them figured out. All right, so let's get going. So we got basics of the EKG rhythm. Let's talk about all the waves here, okay? So we got P wave, a QRS, we got a T, we got this little thing called a U. All right, so what the heck does all of that mean? Got alphabet soup going on. All right, well, let's break it down one thing at a time. So first thing we're gonna do is we're gonna go to our whiteboard so we can do a little bit of drawing. All right, so getting my pen out. So if you had a baseline with no electricity, it would pretty much look like that, okay? A flat line, a systole, as they say, all right? But we're not going to be looking at something with no electricity. We're going to be looking at things with electrical conduction going on. So let's just go from left to right and label everything. So the first thing we're going to have is a P wave, right? And that's a P wave. So P wave. Well, what does a P wave mean? Okay, so a P wave is formed by atrial depolarization. Remember we talked in the last time about depolarizations and repolarizations on the action potential, okay? So a P wave is basically the cells are depolarizing, and this is going to originate in the right atrium in the SA node under normal circumstances, okay? So the P wave should normally, when things are doing what they're supposed to be doing, that should come from the SA node, which is in the right atrium, okay? And as that electricity propagates from the SA node downwards through pathways, it's eventually going to reach the AV junction. And the point of the AV junction is to temporarily delay that electricity, very tiny amount, so the ventricles just have enough time to finish filling. Okay, now from here, we have a P wave. Let's keep going. Then we're going to have something that goes like that. That downward deflection is going to be called the Q wave. And then we're going to have an R, which is kind of a triangle, right? And then where that R ends and goes back up again to the baseline is going to be the S. So this guy over here is your Q. This guy over here is your R. And this guy over here is your S. All right. So where the QRS ends or terminates, wherever that end point is, in this case, if this kept going here, right? That right there is called the J point. So where that QRS ends, and it's going to be called the J point, all right? And the J point is very important. And when we get later on into looking for myocardial ischemia, myocardial infarction, we're going to want to find that J point, because that J point is going to allow us to measure something called the ST segment, which we're going to draw here in just a second. Okay, so let's see, you got the QRS, and then we'll do a T wave. Okay, this guy is the T wave. So let's just back up because we got a little bit ahead of ourselves. So we talked about the P wave, and it represents atrial depolarization. Then we got this QRS going on. Well, what does that represent? That represents ventricular depolarization, delta D, right? So what's happening mechanically now? Okay, cool. We've got some electrical conduction going on. We got atrial depolarization. We got ventricular depolarization. Well, what does all that mean? Okay. These things are supposed to, when they happen electrically, correspond to mechanical activity, physical activity. Okay. So when a P wave occurs and you have atrial depolarization, you should have atrial contraction bilaterally, both atriums. Okay. And when you have a QRS, which is a ventricular depolarization, you should have a ventricular contraction. Okay, so that kind of makes sense when we think about the order in which, anatomically and physically speaking, physiologically speaking, that the heart works. Right, the atriums contract, and while the atriums contract, the ventricles are filling, and then when the ventricles are ready to contract, they do, and the atriums at that point are filling themselves. Okay, so a P wave, which is atrial depolarization, should equate under normal working circumstances to atrial contraction. And a QRS, which is ventricular depolarization under normal working circumstances, should equate to ventricular contraction. Okay, so which one of all these things is really creating a pulse? Okay, well, atriums just beating by themselves don't create a pulse. The left ventricle, the ventricles really, but the left ventricle is really what creates a pulse. So the QRS is really going to be what corresponds to a quote unquote heartbeat. Okay. So from the ventricle depolarization, we're going to move on to the T wave and what's going on the T wave. Okay. So those cells in the ventricles depolarized. Well, in order to depolarize again to cause another heartbeat, they're going to need to repolarize. Okay. And that is going back to the action potential corresponding to the phase that results in repolarization. Okay. And during that period, the ventricles are, for lack of a better term, recharging, resetting, getting ready to do it all over again. Okay. So that's your P, your QRS, your T. Now, sometimes, not often, it's not common, you will have a secondary wave after the T wave that's a little bit smaller, and that's called a U wave. Okay, that is not a common finding. However, it does occur, and we should be, aware of it. So U waves, for them to be what we call prominent U waves, they should be basically greater than 25% the height of the T wave. Okay, so that's one of the criteria for a U wave. U waves are not common, and the most common time that you will see them is in bradycardia. Okay, sometimes you can see it in hypokalemia as well, hypomagnesemia, some other things. But bradycardia is pretty much the most common time in which you're going to find it. Once again, it's not a common finding though. So from here on out, we're not going to even refer specifically to U waves. Just be aware of what they are. Okay, so let's just draw things and label things. So we got what? Let's do it out. P. Oh my goodness, hold on. So we got a P, QRS, T, P, QRS, T, P, QRS, T, so on and so forth, right? Okay, so let's label P, Q, R, well, that's your S, that's your Q. That's your R, okay? That's your T, should be a little bit bigger, sorry. and that is a P, and we got your Q, R, S, T, P, Q, R, S, T. Okay, cool. So let's label some other things. So we have something called intervals, okay? So we have something called a PR interval, and that is basically going to be from P wave to the R wave, okay? And this period in here. This is a period of time, okay? So remember on our EKG paper, we have a time of 0.04 seconds for each small box and 0.20 seconds for each large box, okay? So what we're doing is now we're going to use these boxes. Obviously, we're not on an EKG paper, we're just on a whiteboard right here, but we would count the amount of small boxes in this PR interval, okay? So we want our PR intervals to be a time frame. So basically 0.12 to 0.20 seconds, okay? And that's important because later on when we start getting into learning the abnormal things, you're going to see that something that has a PR interval longer than 0.20 seconds, so maybe 0.24, 0.28, whatever, longer than 0.20, we would say that it has a prolonged PR interval, and that means something, okay? If you're curious, they call that a first degree AV block, but don't worry about that right now. We're going to get into all of that stuff later. Right now, we just need to be able to identify the PR interval, know the time that's associated with it, 0.12 to 0.20 seconds, and what it represents. So if the P wave represents atrial depolarization and the QRS represents ventricular depolarization, the PR interval is the time it takes from the moment which the atriums depolarize until the ventricles depolarize, okay? So it's just a measurement of time. So next, just moving left to right on all of this here, what we can measure is the width of the QRS, okay? So the Q, which goes here to about the S, so about here, and we can measure this width in here, okay? All right, so why does this matter? Okay, what's going on here? The ventricles are depolarizing, ventricles are contracting, okay? So this should happen in a normal duration of time. Some texts will say 0.06 to 0.12, some will say 0.08 to 0.12, okay? The big key though is it should be less than 0.12 seconds. That's really the takeaway, okay? So why? Once again, when we get into rhythm identification, one of the things we're going to ask ourselves a whole bunch of questions when looking at a rhythm. We're going to say, okay, does it have P waves? Does it have this? Does it have that? One of the things we're going to look at is what is the width of my QRS? Okay, is my QRS narrow or is it wide? So basically, the takeaway from this is if you have a QRS of greater than 0.12 seconds, we can say that your QRS is a quote unquote narrow complex, right? If it's greater in duration, because remember, left to right is a measurement of time. So if something is greater than 0.12 seconds, like 0.16 seconds, it took more time to occur, right? Something is being delayed, all right? And that is usually abnormal. So if you have a QRS complex that's greater than 0.12 seconds, you are going to have what we call a wide QRS complex, okay? And that is going to matter later on when we get into our rhythm identification, because you're going to see that certain rhythms, whether they originate in the atrium, like as in the SA node, or they originate, we'll say, above the ventricles, maybe in the AV junction somewhere, you're going to see that those have like narrow complex QRSs. But then when we see things that have wide QRS complexes, sometimes those are going to originate down in the ventricles. It gets even more complicated later on with things called bundle branch blocks, and there's other reasons with which a QRS can be wide as well. But we're not going to worry about any of that for right now. Okay, so for right now, QRS should be around 0.06, 0.08 to 0.12. it's greater than 0.12, it's going to be wide, okay? Next, we're going to look at the QT, Q to the T interval, okay? So why does the QT interval matter, all right? Well, let's back up. What is the QT interval, okay? The QT interval is the time it takes for the ventricles to depolarize and then the ventricles to repolarize again, okay? So why does that matter? Well, when the ventricles depolarize, I'm oversimplifying here, they use up their electricity, right, to cause a contraction, and to do it all over again, they need to be reset. So if the ventricles go to contract again or depolarize again, but they have not repolarized yet, you can see where that starts to cause problems, okay? There's something called an R on T phenomenon, which basically means that the ventricles go to depolarize during the period in which they're repolarizing, and that can lead to detrimental consequences to the patient. So that's why QT intervals matter, and more so as to why a prolonged QT interval would matter, because you increase the likelihood of that R on T phenomenon from happening, which is something that we get into a little bit later, okay? So for right now, you're gonna have, this is not perfectly straightforward. And the reason I say that is you're gonna have a QT interval, and then you're going to have something called a QTC, which you're going to see, okay? And what that just stands for is QT corrected. There's a whole bunch of different formulas out there, and we're not going to ask you to memorize these formulas and do all this mathematical stuff because the EKG does it for you. So that's fantastic, because it gets a little tricky. And if there's a bunch of formulas, how do you know which one to use? So we don't have to worry about all that. So basically what it is that the QT corrected basically factors in heart rate and gender and things like that. So basically we're looking at like around 42, 0.44. Some people say 0.45, depending on whether you're male or female. So that's pretty much what we're looking at for the standard QT interval or QTC. So just kind of like a rough, dirty rule, if the heart rate is under 100, the QT interval should not be greater than 50% of the R to R interval, which we're going to talk about right now. Okay, so that's just something to keep in mind. So the next thing is the R to R interval, which we just mentioned. So now what we're going to do is we're going to look at the R wave to the next R wave to the next R wave. So we got one R wave to the next R wave to the next R wave, okay? So what we're looking at here is we're going to be counting the small and or large boxes in between R wave, R wave, R wave, R wave, R wave, and it should be about the same, okay? It should be about the same. So if you have a rhythm where all of the R waves are the exact same distance from one another, that's how we measure rhythm regularity, okay? So if somebody said, how do you measure the regularity of a rhythm? You say the R to R interval, okay? If the boxes are the same amount of distance, then the R's are happening at the same time intervals, which means it's a regular rhythm. Now, if you have something that looks like this, R, and then you got something like that, and then that, and then that, and then that, and what's going on here, right? So we got an R wave, we got an R wave, we got an R wave, we got an R wave. The distance between these R waves is not the same, okay? So in that particular case, we would say you have an irregular rhythm, because the regularity of the rhythm is determined by the R to R interval. Okay, very good. So next, what we're going to talk about is identification of the baseline, okay? So the baseline, or isoelectric line or isometric line, different terms you might hear used. Really what you want to look at for that is the T to P segment. So like right here, okay? Because what's going to happen is this baseline might get skewed a little bit by what's going on with all these depolarizations and repolarizations occurring, okay? But if you're ever like trying to find where the baseline is, look in between the T and the P. All right. So now, another thing that we want to talk about is this, where the QRS ends, and right here, that would be like there, and right here, that would be here, and that would be like here. So that is what we call the J point, okay? So J point's important. J point is where the QRS pretty much terminates, and we want to compare the J point in relation to the baseline, which we just mentioned on how to find. So the J point gives you an idea of this ST segment right here. So ST segment right here, ST segment right here. And we want that ST segment at the J point, we want that to be equal in height to the baseline. Because when we start looking at 12 leads and we start looking for signs of myocardial ischemia or myocardial infarction, we're going to look at that J point. And if that J point is elevated, which is above, or depressed, which is below the baseline, that can be indicative of either infarction or ischemia or whatever going on, okay? So that's your ST segment. And how do you find the ST segment? You look at the anchor point of the J point, okay? All right, so starting to make a mess on the whiteboard. I hope it's not too confusing. It's hard to obviously read the crowd when there isn't one. So if you're following along, great. If you need to rewind it and listen again a little bit, you know, I get it. Absolutely get it. You know, I was there once upon a time myself. So let's just make sure that we're tracking here. Okay. So just a quick recap. We got P's, atrial depolarization, QRS's, ventricular depolarization, T waves, ventricular repolarization. We got a PR interval, which should be 0.12 to 0.20 seconds. And that's the time from atrial to ventricular depolarization. We have QRS width, right? Should be basically 0.06, 0.08 to 0.12. And if really, once again, we're looking at that 0.12 number. We want it to be under 0.12. That's narrow. Anything over 0.12, we would say wide. So what if we had a PR interval, it's 0.24? We would say a PR interval is prolonged. If we had a QRS that was greater than 0.12, we would say the QRS is wide, okay? Then we have this ST segment with the J point we looked at. That's important, looking at 12 leads for basically diagnosing MIs and things. And then, of course, finding the baseline in between the T and the P. And of course, we have the QT interval, which we talked about. So just something else to kind of throw out there for you guys for the QT interval. This is important to pay attention to. And if it's normal, fantastic, kind of go about your life. But if it's prolonged, we have to ask, is this naturally prolonged? Like, because there are people that have naturally prolonged QT intervals. It's just the way their heart is wired. All right. But there are medications that are commonly prescribed as prescribers and practitioners that you're going to be using that have an effect of prolonging a QT interval. Okay, so just kind of throwing some out there, not picking on anybody or any manufacturers or anything, but just drugs that have been known to increase the QT interval. Common drugs, so antiemetics such as ondansetron, a lot of the psych medications, sumatriptan, Haldol, things like that have done it. Common antibiotics, which include macrolides and fluoroquinolones, those can prolong the QT interval as well. And fluconazole, things like that. So you just got to be careful, right? Because if you have a patient and, you know, they got some sort of infection and, you know, I don't know, a macrolide of some type is the indicated antibiotic, and they have a, you know, QTC of 0.5 something or whatever. Hey, maybe do we have an alternative to this particular medication that won't prolong this QT interval and potentially cause problems with the patient, you know? So these are just things clinically to think about, right? Because, you know, we're talking about EKGs here, but medicine, you know, it all ties together, all right? It all ties together. So we always got to be looking to tie in all of the other things that we learn in our AMP, our ClinMed, our pharmacology. We got to learn and we got to tie it all together. Okay. All right. So that's pretty much where we're at for right now. So we're going to go ahead and clear this whiteboard. We're going to go back to the PowerPoint just for a minute and see where we're at. All right. So got the basics of the EKG rhythms, what means what, what's going on. So that's good. That's important. So make sure we definitely want to know that. Talked about QT intervals. We talked about the leads last time. Something I didn't mention was the posterior leads, which I'm going to just briefly touch on here. So we talked about V1 through V6, okay, and on a normal EKG, we just do V1 through V6. If for whatever reason clinically you have a high index of suspicion that there might be something going on the right side of the heart, then we would do a V4R, or if we wanted to, we would just do a complete right-sided chest 12 lead. The V4R is just like a quick thing, you know. If you want to be more thorough, you can just do the right side all the way through. So we talked about the placement of all of that. I just want to highlight that when you're doing a 12 lead, guys, and you're doing all these different camera angles, I like to call them, of the heart, V1 through V6 are pretty much looking at the left ventricle. Okay, so you're thinking to yourself like, well, why would I ever want to look at the right ventricle? Like, why do I care about that? Like, what's going on? Okay, so when you look at the different leads that V1 through V6 provide you, you're looking at the left ventricle. We're looking at the anterior portion of it, well, septal portion, the anterior portion. We're looking at the lateral, high and low lateral portions of it, and we're looking at the inferior portion as well of the left ventricle down at the bottom. So the left coronary artery primarily supplies the left side of the heart, and it breaks down into smaller things like the left anterior descending artery and left circumflex artery, right? But the inferior portion of the heart is actually supplied by the right coronary artery. So depending on where an occlusion is on the right coronary artery, if it's farther upstream, as they say, you might not only have infarction of the inferior portion of the left ventricle, but you might have infarction of the right ventricle also, if that right coronary artery is being affected. Okay, so once again, we're not there yet, but something that I'll just throw out there, if you want to just put it in your brain for now, is that anytime in the inferior leads you have suspicion of an MI, you always want to go and check the right side of the heart with a right-sided EKG, and bare minimum V4R, or a right-sided EKG. So let me find this. Okay, so if you do a V4R, for example, you're doing a 12 lead of all the same leads, all the same lead placements, except V4. You just move it over to the right side. When that EKG prints out, you need to physically write on the paper an R next to whatever you changed. So it says V4R. So that has to do with continuity of care, right? So if I print out a V4R, it'll give me the whole 12 lead. It'll give me all the leads. It's just V4 is the right side itself specifically, okay? Well, if I look at it and I go, okay, cool, and I throw it in the patient's chart, well, the person after me, they don't know that that's looking at the right side. So it's a continuity of care. It reduces medical errors, and that's something that we always need to be cognizant of. So write that R there. If you do a complete right-sided one, write R next to all of them, okay? All right, so same thing, with the posterior, okay? For V7, V8, V9, if you need to move leads to make that happen, as you can see on the PowerPoint, it gives you the anatomical locations. And you might be thinking, well, why would I want to do that? I'll just tell you, that's not something that we do standard. Like if a patient comes in, they're like, oh, I have chest pain. And I'm like, okay, let's do a 12 lead. I'm not doing a posterior 12 lead on every chest pain that comes in. It's just not something we do. But if I have a clinical suspicion, I lost the slide there. Where'd it go? If I have a clinical suspicion based on EKG findings that warrant investigation of the posterior wall, then I absolutely will do a V7, 8, 9 just to see what's going on. So for right now, we're not to the point yet where we're diagnosing MIs and looking for myocardial ischemia and an infarction. We're not there yet. Okay, so don't worry about that just yet. Just know where they go for now, and why would I want to do it? Because I have clinical suspicion that needs to be done. Okay, so that's pretty much where we're at right now for that. Okay, and then of course, if you do a posterior and you print out a 12 lead, you need to mark it. So put that 7, 8, and 9 on the 12 lead, because the person after you, they won't know that that's looking at the posterior. Okay. All right. So let's see, what else do we got here? Just kind of briefly throwing some things out there with the leads. Make sure that you have a good contact between the electrode and the skin. If the skin is wet, there's a lot of hair. I've actually, this is, crazy, but I've actually had people that really just like lathered up their arms in like cocoa butter, lotion, whatever the case may be, and the leads are just not getting good contact because they have so much lotion on their skin. So these are just things to be aware of, because ultimately we have to have good contact between the electrodes and the skin to get a good electrical conduction to read our EKGs. All right. So let's talk about the fundamentals of the tracing. We've talked about the small boxes and the big boxes. The small boxes are 0.04 seconds. The big boxes are 0.20 seconds. Okay. So if that's the case, how many, because you might get asked this as a question, right? How many large boxes equals 1 second? Okay. Well, your answer should be 5 large boxes, because 0.20, 0.20, 0.20, 0.20, 0.20, right? 5 of those is 1 second. So if we needed to do a 3 second, just figure out, well, how many boxes in 3 seconds? Okay. So if 5 is 1 second, 15 would be 3 seconds. So 30 would be 6 seconds. Okay. So just something to keep in mind, because we're going to need to know that as far as calculating rates and things like that go. All right. So let's talk about calculating rates now. All right. So let me find it here. All right. So you have a couple different methods here. You've got something called the 300 method. You have a 6-second strip method. Okay. You have a 500, or I'm sorry, a 1500 method. You got different options here. So if you have an irregular rhythm, okay, so let's look at this rhythm strip down on the bottom here. Let me get my pen out. So this is kind of hard for you guys if you've never seen this before to see what's going on, because you look at all this stuff here and you're like, well, that doesn't look like any of the waves that Simon was drawing on the screen. I don't know what all that is. Okay. I don't blame you. Basically, you have a patient down here in atrial fibrillation is what's going on. But for right now, don't even worry about that. Let's just do one thing. Let's look for the R to R intervals. So remember we talked about R to R intervals. So what do we got? Let's find our R's. So that's an R, 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 R. I sound like a pirate right now. R, 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 R. Okay. So not the same distance, not the same distance. So what did we say about irregular R to R intervals? That means it's an irregular rhythm. So it gets a little tricky, right, when you're going to calculate an irregular rhythm as far as the heart rate goes, because the heart rate's constantly changing. Okay. You'll see a patient and you put them on the monitor, EKG monitor, and their heart rate will be like the number on the monitor will be 98, 197, 62, 148, 42, 212, right? And you're like, well, what is going on here? Well, the patient's heart rate is not bouncing around like in 200 point interval swings, right? That's not what's happening. The computer is basically calculating the rate from one R to the next. And every time that R changes in width between this one to that one to that one to that one, it's a totally new rate every time. So the computer can't figure out what's going on sometimes. So what you got to do is you just do an estimation, okay? And you take a 6-second strip. So how do we know it's a 6-second strip? Well, you can count the boxes if you really want. So 6 seconds equals 30 big boxes, okay? Yeah, each second is 5 boxes. So yeah, each second is 5 boxes. So that means that 6 seconds equals 30 big boxes. Okay, good. So if you look at these hash marks here, right here on the screen, each one of those is going to basically represent 3-second interval. Okay, so from like this guy to this guy to this guy as these hash marks go. That's going to be 3 seconds. So that, how do you know it's a 6-second strip? If you have those hash marks, it makes it easy. Not every EKG out there, EKG machine is going to be user friendly and give you these hash marks. Most of them do. But just, be able to identify a 6-second strip if they don't give you the hash marks. Okay. So what we're going to do, this is really easy, guys. Find a 6-second strip, which this is, this guy down here, this 6-second strip. Okay. Count our R waves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. We're not counting this guy because he's outside of these two hashes. Okay. So what did we say? 11. So whatever you come up with, whatever number that you come up with, 7, 8, 9, 10, 11, whatever, we came up with 11, you're always going to just times that by 10. Okay. And this is an estimation. So this person's estimated heart rate would be around 110 beats per minute. If you really like sat there and counted it, how many times, it might be 112, it might be 108. We're just doing an estimation though. And it's pretty close, and it's definitely close enough to work for what our needs are. Okay. All right. So what do we got here? Get rid of my pen so I can move the screen here. Hold on one moment, having a little bit of technical difficulty here. So going back to this PowerPoint here, guys, I was just kind of reading off the PowerPoint. It says here, let me point this out to you here, get my pen. Yeah, it says each second being, oh no, we're good. I'm sorry, I apologize. Getting too many birthdays here. All right, so let's move on to what's going on. I'm sorry. Sometimes it's a little challenging doing this online here. All right, now we're looking good. Okay, so let's count these rates. All right, so let me move this out of the way so I can see what I'm doing. So we got a couple of rhythms here, guys. I don't expect you to like know what these rhythms are. Don't worry about any of that stuff right now. We haven't really got there. Okay, so in this particular case, different machines do different things. So this guy right down here, you have 3-second hash marks, right? And then this guy up here, you got 1-second hash marks. So 1, 2, 3, 4, 5, 6, right? Or it's just different ways the machine presents things to you. So you just kind of got to know what you're working with, all right? But either way, if you have a 6-second strip, you just count the R's. So 1, 2, 3, 4, 5, 6, 7. So 1, 2, 3, 4, 5, 6. So count. Technically, we shouldn't count that guy, but it's right on the borderline. Okay. But either way, you count up how many R's, and then you would times it by 10. And then the same thing here. So how many R's do we have? 1, 2, 3, 4, 5, 6, 7. So the heart rate for this guy would be roughly about 70. Okay. So that's just how the 10-second method works. So let's, all right, let's move on to the 300 method. Okay. So once again, this is kind of just like a quick, rough estimate type thing. It does give you, exact numbers if it falls perfectly on the line. So, somebody handed me an EKG once and they were just like, hey, look at this real quick. And I was just like, instantly, I was like, oh, heart rate's 150, and the person's, how do you know that, and you just know by this 300 method, right? It's just kind of like a quick little tool you can use to quickly identify things. So what we're going to do, let me get my pen out. What we're going to do here is we're going to find an R wave that lines up right on a big box. So like this is a big box right here, okay? That's a big box. And that R wave pretty much lines up right on that box, okay? We're doing that to make our lives easy, all right? So let's pretend for the sake of argument from this big box here to this big box here, there was another R wave. Like the next R wave, like this R wave, let's pretend it was right here, okay? If that's the case, the heart rate you could automatically say is 300, okay? Let's say the R wave was not, the next R wave was not right here. Let's say it was right here. And that's where the next R wave fell. Okay, then I could say two big boxes, heart rate's 150. If it fell right here, the next R wave, you could say the heart rate was 100. If it fell right here, which it does in this particular case, but right here, you could say the heart rate's 75. Right here, 60. Right here, 50. Right here, 43, so on and so forth. You get the point here, okay? So that's pretty much the 300 method. So that's something that if you just kind of like memorize, you can just quickly, you can just quickly do things real quick. So, if I was to give you an EKG and I was like, hey, what's the rate of this? And you were like, oh, 1, 2, 3 big boxes, heart rate's 100, right? From one R to the next R. Now, this only works, this is very important, this only works if you have a regular R to R interval, or a regular rhythm, we mean, okay? If you have an irregular R to R interval, irregular rhythm, the 300 method does not work. So if you have an irregular rhythm, what do you need to do? You need to use the 6-second method, okay, that we just talked about a little bit before. You use 6-second method, irregular, you can use the 300 method, regular, okay? So there's another way. I don't think that we have it in the PowerPoint, but let me just look here real quick. Oops, let me get my drawings off the screen. Yeah, there's another way. It's not on here, but it's good to know. And this only works again for regular rhythms, okay? So let me just find something here. Is that regular? That looks regular. Okay, cool. So this guy, we're looking at this. Oops. Hold on. Annotate. Draw. There we go. We're looking at this guy up here. Okay. So let's look at our R's. So R, so on and so forth. Boom. Okay, cool. What you can do, it's really hard to see on that particular paper, but what you can do, especially if things get very fast, the R to R's get really close together. So then it gets kind of hard to calculate the rate sometimes. So what we can do is we can do something called the 1500 method. So here, let me get my calculator out, just because I want to be correct. All right, so what we can do is we can count from one R to the next R. And what I like to do is I like to find an R that ends right on the beginning of a big box, because it just makes my life easier when it comes to counting. So if I was going to do that, I would grab like this guy, or maybe that guy or that guy, or, so on. You get the point, right? So, but this one looks good. This one, I mean. So we can count the small boxes. Now you can't really see, but if you really look close and you really zoom in, you'll see that, there's 5 small boxes here. There's 5 small boxes here. Okay, so that comes up to what, 10 small boxes. So the 1500 method, what you do is you just, 1500 is what do they call it in math? A constant. Okay, it's just a constant. It's always 1500. You take however many small boxes you counted, in this case 10, and you divide that into 1500. So 1500 divided by 10. You shouldn't need a calculator for that, but that gives you the exact heart rate. It's not estimated, it's exact. Okay, so that's pretty cool. In this case, 1500 divided by 10 is 150. So this exact heart rate of this particular rhythm is 150. And that actually corresponds to what we just said about the 300 method. Because if we did the 300 method, if the R was here, it would be 300 heart rate. If the R was here, it would be 150. If it was right here, it'd be 100, right? You get the point. So two big boxes corresponds to 150 on a heart rate on the 300 method. Or if we do the 1500 method, we count the small boxes in between two R's and we divide that number, so 10 small boxes in this case, divide that into 1500, that gives us 150. Okay, so that's just another way of going about things. All right, so I think that's pretty much it for heart rates. Really easy, guys. Just remember when to use which thing. Okay, what else do we got here? So the importance of the heart rate, is really important to quickly recognize heart rates. Like when you guys take ACLS, one of the things that we're just literally going to ask ourselves in the beginning is, does it have a pulse or does it not? Okay, cool. It has a pulse. Is it too fast or is it too slow? Right. And then we go from there. So it's like one of those things, like you got to be able to quickly recognize something that's a tachyarrhythmia or a bradyarrhythmia. All right. So why, right? Well, I always try to know the why behind things, like why does something matter to me? Well, if you have a tachyarrhythmia, right? As the ventricles are rapidly contracting, they're not getting time to fully fill. And if a ventricle is not fully filling, that leads to, well, Starling's law, right? So if you're not fully filling, you're not fully expanding, you're going to lose contractility because you're losing the stretch, right? It ultimately leads to reduced cardiac output. That's the big thing here. And remember, the cardiac output equals heart rate times stroke volume, and blood pressure equals cardiac output times systemic vascular resistance. So if cardiac output goes down and nothing else changes, blood pressure goes down. And now you start getting, lack of perfusion, all the problems that come along with lack of perfusion. We'll just say that, okay? Same thing with bradyarrhythmias, right? Actually, let me back up for another thing with tachyarrhythmias too. You also got to take the patient's condition into account, right? So if you have a 20-year-old athlete, he might be able to sustain a heart rate of 190 for a longer period of time than a patient that is a geriatric patient that maybe has multiple comorbidities, things like that. They might not tolerate a heart rate of 190, 200 as long as that young, healthy individual it would, right? So that's just why, things like that matter. Same thing with bradycardia, if the heart rate is too low, you're not going to get perfusion to the brain. You're going to get syncopal episodes, unconsciousness, hypoperfusion, shock, all of the things that come along with that. And then ultimately, hyperperfusion of the heart as well. So that'll lead to ischemia, which just complicates the problem. So that's why, it's important to recognize tachy and bradyarrhythmias, right? So just something to kind of throw out there as far as interference is concerned. If you have a patient that you're doing a EKG on, you have to get them supine, preferably relaxed, not moving, perfectly still. When I do it like a 12 lead, for example, like right when I'm about to press the button, I tell a patient, like, real quick, ma'am, sir, whoever, like just no moving, no talking, just for a second, just a couple seconds, right? Even if they're talking, it can mess this up. So if you're looking over here, if you're looking over here towards, this tremors, right? You have a patient having muscle tremors, you're going to get all this stuff here on EKG. And if you're trying to interpret a rhythm, you can't do it with that. It's not going to work. And then, of course, if you get movement, you get this, what we call a wandering baseline over here. That's not going to work either. Okay. And then this is not super common. This stuff down here. This has to do with literally like electrical interference. Okay. They call it 60 cycle, 60 hertz interference. Has to do with basically electrical interference. Your EKG leads are not properly grounded, like you have wiring issues, like things like that. Sometimes unplugging and replugging in the leads might into the machine itself might might fix it, or sometimes there can be electrical equipment around the patient which causes it. That's not really common anymore. That was a problem more like a long time ago. Or if you can't figure it out, you might just need to get a different machine, right? So might just need to be serviced. So that's pretty much that for like interference. Just all that stuff we call like that squiggly lines and stuff when we're trying to read the EKG. The term for that is called artifact, right? So if you're taking EKG on me and I'm talking and I'm moving my hands all around and EKG starts going all over the place and it gets like you can't even read it, basically we would call that artifact, okay? And the goal is to not have artifact, all right? So things that we talked about right now, we talked about how to identify the EKG, I'm sorry, the heart rate based on the EKG. Other things that we talked about were the waves and what they correspond to. So that's all really important as well. So let's just kind of quickly review, up and down on the EKG measure what? They measure amplitude and positive and negative deflection. I'm not really looking at a particular slide in general. I'm just talking here. We're just kind of reviewing. Up and down measure positive and negative deflections. Left and right measures time. Small box 0.04 seconds. Large box 0.20 seconds. 5 large boxes equals 1 second, right? So just be aware of how that works. P waves, QRS, T, right? So P wave, atrial depolarization, QRS, ventricular depolarization, T wave, ventricular repolarization, okay? Something that I'm going to point out that we didn't talk about actually, I apologize, is the refractory period. I know it's around here somewhere. I might just draw it. Yeah, we're just going to draw it. White screen. Need an assistant. There. Oh, geez. Man, that looks terrible. I didn't realize I drew that bad. No, I definitely realized I drew that bad. Okay. All right. So relative refractory period. Let's talk about what all that is. So P wave, QRS, T wave. Okay. So your absolute refractory period is pretty much going to go from like here to like here, like the beginning of the T wave. Actually, let me do a little bit better job. So from here to like here, right? That's going to be your absolute refractory period. Okay. And what's happening here is the ion channels are closed and they're not able to respond to an electrical stimulus. Okay. An external electrical stimulus, for example. Okay. So let me do a better job of drawing this. Hold on. So we're going to go from about here to about here. So that's looking a little better. So your absolute refractory period, okay? So then you have a little tiny window here from about the middle of the T wave, maybe 1/3 of the beginning of the T wave, right? And this is called the relative refractory period. So absolute, so this is relative refractory period. This is absolute refractory period, okay? So why does all this matter? Like, okay, why? The why behind everything. So the absolute refractory period, basically you have some ion channels that have been closed and they're not able to respond to an electrical stimulus. So why does that matter to us clinically? If we need to, for example, do a procedure on a patient called a cardioversion, this is something that we do in unstable patients and tachyarrhythmias. I'm not going to get into it because we haven't covered it yet, but that is a procedure that we would do. If we delivered electricity in an absolute refractory period, these cells are not able to depolarize, okay, to that electrical stimuli. However, if we did not deliver the electricity at the appropriate time, and we delivered the electricity like during the relative refractory period on the back half of the T wave, those cells have ion channels, which are open and able to respond to an electrical stimulus, but they're not ready to. So the cells, as we say, are hyperexcitable at that point. So they would respond to an electrical stimulus stronger than they normally would, and that would lead to detrimental consequences to the patient. You can actually, like if you cardioverted somebody at that point incorrectly, um, you could actually put them into VFib and kill the patient. Like it's a very real thing. Okay. And we obviously, of course, never want to do that. So it's important to know what to do in medicine. It's also important to know what not to do. So that's definitely a what not to do thing. So if you're worried about that, don't, because all you have to do is press a button on the monitor and it figures out when to deliver the electricity for you. That button's called the synchronized button, but you don't need to worry about that. We talk about that stuff later, but just in case your curiosity was piqued. Okay, so that's the deal with the absolute and the relative refractory periods. Definitely want to know those, why they're important. So let's go back to our PowerPoint. And I think that pretty much probably sums everything up for the most part. Okay, so let's just kind of do like a quick little rehash of everything here. I would suggest going through all these questions and making sure that you know these things and knowing the takeaways from today's lecture. What is the normal electrical conduction pathway of the heart? We talked about the SA node, the AV node, the Purkinje fibers. What else do we got? Know the intrinsic heart rates or pacemaker. The intrinsic heart rates of the different pacemaker sites, being the SAAV, Purkinje fibers. What makes cardiac cells unique and different than other muscle cells? Well, that goes into that thing called automaticity that we talked about. Resting potential of a cardiac cell, we talked about that, negative 90 millivolts. Phases of the cardiac action potential. So, you can go back and just review the action potential phases that we talked about earlier. What ions enter and exit the heart through depolarization, right? Basically a depolarization, to summarize things, is a sodium goes in, calcium goes in, and a potassium goes out, right? And then the repolarization is kind of the opposite of all that. And what is a cardiac cycle? That's not something that we talked about, right? So actually, let me just show you real quick. So if you had a P, a QRS, and a T, and a P, a QRS, and a T, okay? One P, QRS, and T, as in that to that is a cardiac cycle. Well, what is a cardiac cycle? Well, I would say it's one heartbeat, right? So what does it take to have one heartbeat? Normally, it takes a P wave, it takes a QRS, and it takes a T. And then your heart is ready to do it all over again. So one cardiac cycle is basically a P, a QRS, and a T, all right? All right. What else do we got? Absolute, relative, refractory periods. We talked about that. What's the importance of knowing these details? Well, because the absolute refractory period, things are not able to respond to electricity. Relative refractory period, they really don't want to respond to electricity. Not a good time to apply electricity. EKG fundamentals, we talked about the small boxes and the large boxes, and the hashes we talked about. Make sure you know which leads are which, guys. So know your unipolar, bipolar limb leads, right? Know your augmented voltage leads. Okay, so 1, 2, 3. And then what do we got? We got AVR, AVL, AVF, our augmented leads. And then of course know your chest leads, right? So V1 through V6. Know the anatomic locations of where to put the chest leads, okay? And then know the parts of the EKG. So your P wave, your QRS complex, your T wave, your PR interval, your QT interval, your R to R interval, okay? Know the common methods of calculating the heart rate, which we talked about. So you got irregular rhythms, you can use that 6-second method. Regular rhythms, you can use that 300 method or the 1500 method, okay? No common artifacts for the EKG. So movement, wandering baseline, 60 cycle interference, no things like that. Okay, so that pretty much wraps up our first lecture. So I know this is kind of a lot of stuff, guys, like all at once, and I have total confidence in all of you guys. I believe in you guys. I know we're going to get this, and we're all going to do it together. So if you have any questions, once again, please, don't let those go unanswered. And however you need to answer them, whether it's reach out to me or us, or whether somebody else in the class, self-directed learning, it doesn't matter. Whatever you need to do, but we're here for you. That's our purpose as professors and educators. Okay, so don't be afraid to ask a question. Don't think it might be silly. Ask. I promise there's probably somebody else that's thinking the same thing as you. Okay, and every single thing in EKG builds on the next thing. So that's why you don't want to leave things unanswered, because you're going to have a hard time understanding the next class's concepts if you don't have this class's concepts. Okay, so once again, um, thank you for tuning in. I appreciate all of you guys, absolutely. And, study hard. We'll see you next time. Bye.